Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. As you can see, I just took off my mask. You know, what can I tell you? This is not Democrat or Republican. It's not, it doesn't even know what it is. What it does, though, is it protects myself, my family, and others. So think about it. Think about the mask. That's my homily for the day. Today we have a very important individual, someone who is very well known in the world relative to his lymphoma expertise. I'm not just talking about the state of Florida or the United States. I'm talking about the world. So let me introduce Dr. Craig Moskowitz, MD, who is a professor and physician in chief of the oncology service line at the University of Miami Miller School of Medicine. And of course, that's the University of Miami Health System is an adjunct of the School of Medicine. So welcome, Dr. Moskowitz, welcome.
Oh, thanks for having me. I really appreciate it.
I will tell the folks, I always tell you that, you know, that this program we've been going for well over 22 years, and our questions really come from the viewers. And the three most, we do a look at it every couple of years, and the three areas which are most specifically asked about are cancer, cardiac disease, and believe it or not, minimally invasive surgical techniques. Those are the three that end up being the ones. And you being such an important person in the world of oncology, Dr. Moskowitz, thank you very much for being here. Tell us about the general oncology service line at the University of Miami Miller Medical School, and I guess it's associated with the Sylvester Center, I would assume.
Yeah, so the University of Miami Health System really is divided into four silos. There's the University Hospital, the Baskin Eye Institute, the Sylvester Comprehensive Cancer Center, and then our large network, which goes 35 miles north and south. The Cancer Center is sort of divided into sort of 7 or 8 silos. There's surgical oncology, radiation oncology, neuro-oncology, pediatric oncology, and the solid tumor, liquid tumor, and transplant and cellular therapy components sort of make up the Cancer Center. I'm a lymphoma expert. I'm a liquid tumor physician, but I oversee all of those silos at Sylvester. And, you know, I've been here now about 3¼ years. Prior to that, I worked at Sloan Kettering in New York for 25 years. So this is my second position in oncology. That's sort of an overview of our Cancer Center.
Talk to us generally about, you know, cancer is such a difficult thing to talk about because most people think of the onerous nature of cancer. There's been such a dramatic shift in knowledge in the area of cancer therapy and the ability to get early intervention.
So I think that it's not a simple answer, but you know, cancer is just one word, and there are literally thousands of different subtypes of cancer. And it's easy to put them into a few buckets, however, that, you know, the audience that listening to can think about. There are those cancers that are curable easily. There are those cancers that are curable with a little bit more difficult treatment. There are those cancers which will have chronicity to them, and I just like to call them a chronic condition, and I'll focus on that in a minute. And there are those cancers that that are, of course, impossible to help. The last category are usually when folks come to the oncologist really sort of almost towards the end of their life, and it's almost impossible to prolong their life. And that's actually very uncommon. Those cancers that are easily cured, bucket number one, are those that are found early, tend to be those that can be fixed with surgery, or those that are found early that can be cured very easily with chemotherapy. Those are very simple to cure, and 80 to 90% of the patients are cured in that setting. The second group, which is not overly common, is those cancers that are curable but not easily cured. And those tend to be the liquid tumors that are spread throughout the body that can be cured with chemotherapy with or without additional treatments. The problem is with those is that if they're not cured, they usually cause trouble quickly. Despite the fact that we do have a good handle on those. But the biggest bucket are those that are chronic. And that can be a wide variety of different cancers. And I like to use two examples. The first example is a patient with what we call follicular lymphoma, which is a slowly growing non-Hodgkin lymphoma. When I was training, quite a long time ago now, the median survival of those patients were 7 years. And in fact, my wife's grandfather died from follicular lymphoma. Back in 2012, so this would be about almost 20 years into my career, the median survival of that disease doubled to 14 years. And now 9 years later, the median survival of this disease is about over 20 years, and we're not even sure how long it is. And the median age of the folks who get this disease is 58. So you can think about it as a disease that you're going to have the rest of your life with ups and downs. There are tons of new treatments that can help these folks. And it's very analogous, for example, to having any other chronic condition. And I like to use the term I like to use diabetes in a comparison, which of course a large number of folks in the United States have. When you get diabetes when you're 60, a lot of times you'll start off with being on diet control, and then you'll be on a pill, and then you may need to be on an insulin and a pill. But sooner or later, diabetes is going to be a problem, either with heart function, vision, kidney function, and people die from diabetes. And it's something that's treated continuously. Follicular lymphoma is not that much different. It is something that is treated but on and off. And in reality, very few people die of follicular lymphoma anymore. They die with follicular lymphoma. So that's a chronic illness. But the other example I'm going to give an example of my mother. So back when I was a junior attending at Sloan Kettering, my mother came over to me and she said, Craig, what's this? And she shows me a lymph node in her neck. So I said, Mom, where did you get that from? Oh, I don't know. I don't pay attention to myself, is what she said. Anyway, to make a long story short, I hope she had lymphoma, but it turned out she had lung cancer. And she had lung cancer that spread everywhere, not surgically, could not be surgically taken out. She got optimal care, and she lived about 19 months. Now, of course, I was happy with that because I knew it was a problem. My sister was, of course, devastated from the beginning. But that same exact presentation right now, in 2021, my mother probably could have lived between 5 and 7 years. And that doesn't seem like a lot. But just think of what happens during an additional 5 to 6 years of life, okay? There are weddings and there are parties and confirmations and bar mitzvahs and graduations that people can make. And every year, we are improving the numbers in some of the deadliest cancers. So I think there's been great advances. Back in 1997, everybody got the same treatment for lung cancer. Now, there is lung cancer is at least 10 or 12 or 15 different diseases, and are treated differently based upon the genetics of the underlying cancer. And these newer treatments can cause prolonged stability and growth. So there's been tremendous opportunity in some of the more common cancers with improving lifespan 3 or 4 times what it was back just a quarter of a century ago. So, and in fact, because of that, one of the biggest issues that we have in the oncologic community is a lack of oncologists. So you can imagine back, in 2000, when folks would get a bad cancer and they'll live only a certain period of time, and they would see the doctor, 10 or 15 times, for example. Now we can have that same patient who could see the doctor 100 times or more. So there's a national shortage of oncologists, and it's a real major issue in the United States. And many of us are trying to work on that through education, but still it is an issue. So that's kind of a long preamble into kind of where cancer care is right now.
You're the second individual within the last few weeks that has told me about the fact that we have a very severe shortage of some super subspecialties, and you're talking about oncologists, which is sad because the value of the knowledge base has doubled, tripled, quadrupled over the last 10 years with reference to oncologic science and techniques. Am I correct?
Yeah, you're 100% right. I think one of the things that we need to train folks for is that once a patient has a diagnosis of cancer, a lot of physicians there's like a fear factor, and they sort of don't make a lot of decisions until they speak to the oncologist. In reality, what we need to do is to be training the primary care folks and the internists into managing patients who are in the survivorship, patients who are done with their treatment. They really need to be returned back to their primary care and folks and internists, and be managed by those folks and be dealt with all of the what we call survivorship mode, as opposed to keeping them with the oncologist. There's a real bond between the patient, the oncology patient, and the oncologist. And especially when the treatment is over and a lot of the visits are really social, quite frankly, especially in patients who have a low risk of relapse. In reality, it would make a lot more sense if the patients were returned to their home physician, who can manage the patient, and if there's an issue, the patient can then be referred back to the oncologist. That pathway does not happen enough. If that would happen, it would open up more slots for oncologists to see active cancer patients. And we're in the midst of trying to do that at of trying to bring in primary care into the mode of survivorship by doing certain types of research programs with them, especially issues with screening, issues about looking at cardiac dysfunction, issue about looking at endocrine dysfunction, and trying to let the primary care person be the quarterback here, and only to return to the oncologist if there's an oncologic problem. That's going to take a little while to sort out, but I do think that will be extremely helpful. And of course, as you know, the other issue with primary care is compensation. Historically, primary care folks had the lowest compensation compared to subspecialists. I'm a subspecialist, but compared to specialists, and that scenario is changing. Many medical schools have separate pathways now just for primary care. That didn't happen in my day, but that is happening now with different courses and instruction to promote primary care back into the community. So I'm hoping that there'll be a little bit of a turn. That doesn't change the fact that we have an oncologic cancer shortage of docs.
No question about it. And really it relates to many different other issues as well. I mean, we had a program which we did on cardiac care, and the dramatic changes in cardiac, shall we say, rehabilitation, with the minimally invasive techniques and things of that nature. But yet, there are people who are not being, shall we say, viewed by a primary care physician because, to tell you the truth, not to denigrate any of these wonderful physicians that have given us care for the last 40, 50 years, but many of them were not trained in the area of communicating in a collaborative and interdisciplinary way.
Now with Epic and with like universal charts and things like that, I will say that it is definitely a lot easier to take care of a patient now with, with the computerized systems that we have, and getting records is definitely a little easier now. With Care Everywhere, it's very helpful. And if your system is hooked up to Care Everywhere, I think that it definitely saves some time when evaluating new patients, and especially with evaluating patients who are seeing multiple physicians. But you have to be up and running with Epic.
And you have to have the advocacy of people like yourself. I mean, I happen to know of your international, shall we say, gravitas in the field of lymphoma. I guess you'd say cure, work, etc. But I mean, if you just kept it to yourself, it would be of no value except to you and the patients that you see. But yet, you're really a prominent person in allowing other people to receive your knowledge, which I think is very masterful. I think it's very important. And one of the things that I think, again, I'm getting back to this insidious pandemic that we're going through now with the COVID, but I think that that people are waking up that there are not enough medical professionals available for their care. It isn't just hospital beds, it's medical professionals. And, I really applaud you for what you just said. Let me ask you this question about the oncologic service at the University of Miami. I know that I would assume that the bulk of your in-service hospital work is at the Jackson Memorial and U Health. Is that correct?
It's pretty much just at U Health. We do altruistic work at Jackson. We help Jackson just because we're all interested in helping the community, but we don't have oversight of Jackson's oncologic care other than teaching and rounding in the hospital. It's a separate system. The University Hospital, because we're a PPS exempt cancer center, half of the patients that are at the University Hospital are cancer based. So we always have over 200 cancer patients in the hospital, and there's separate people, and of course there are multiple services there that take care of the patients. I want to go back for a second to a point that you made about spreading the wealth, which I think is very important. And it's actually, it's one of the things that has happened during the pandemic that it's actually changed the way we communicate our work. So, as you know, we're having this interview on Zoom as opposed to sitting next to each other, and of course, it'd be nice to sit with each other and socialize. But pretty much all lectures now are virtual, and it's even more interesting is that attendance on lectures have tripled as opposed to in person. And I don't believe that lectures, like for example, your weekly grand rounds or your tumor boards or things like that, are going to go back to in person. It's going to continue virtually because of attendance. Second is that I think all doctors should be on Twitter. I, of course, was kind of resistant to this in the beginning because I'm a little older and not as computer savvy. But Twitter is a really good way to get additional information on what's going on, what's recently been published, new ideas. And thirdly, I answer everybody. Anybody emails me, and I've been doing this my whole career. It's probably not the right thing to do because, legally, but I don't know. If somebody asks another physician emails me about a case, I always answer them and tell them what to do. It's not like I'm seeing the patient, but I want to make sure that the lymphoma patients get the best care. So it's usually not a long answer, but it's usually a long question. But I always answer any physician worldwide that asks me questions. I just did a lecture. I just did a lymphoma lecture for the folks in Sydney. Now, I would never do something like that, and of course, it was an awkward hour. But they heard about an updated research program in one of the lymphomas because of now this virtual format. So some of the things, especially education for physicians, I think is become more robust and definitely better attended because of the virtual platforms that we're doing.
I don't disagree with you. We're finding the same thing here at Nova Southeastern University. With all the students. For example, we have like 3,900 health profession students on this campus. And we have what we call a blend flex system where the student might be in a room, not in a residence room, but whatever, in an apartment, or they might be in the lecture hall, but their attendance is really dramatic, and we see it, and we see it in the desire. I think there's a public persona desire to tell the healthcare professionals how important they are in our lives. Maybe in an oversimplistic way, but they're saying it. And I think it will play well. I think it will, particularly in the areas which are so underserved. We have huge portions of various states with high population numbers that are totally unserved. So I salute you for willing to not only talk to the people in Sydney, but to step out and offer your knowledge to your fellow physicians and otherwise. Thank you. We're down to the last minute and a half of this show, and even though you're from Brooklyn, I have to say goodbye. Not because I want to say goodbye, but only because you're a wonderful guest, and I'm really very proud of the fact that you chose to give us some time, because you are really, I can say this because I know, and in my research of your importance internationally in the area of lymphoma, we're very proud that you became a guest of this show, and your advocacy for better health care, more resultant care for the patients, and we thank you. I thank you for the people that are watching.
Well, really, thank you very much. I came down here. This is a huge area, South Florida. The catchment area is almost 7 million people. I'm convinced that that U of M and specifically Sylvester can be the Harvard of the South here in oncologic care, and we're making that happen. There's been tremendous recruiting. tremendous science. The NCI designation is very helpful. We get all new drugs that nobody else has in the state other than Moffitt, which is 280 miles away. So we're here to help the South Florida community. And we live here. We want people to do well. We know we have a tremendous diverse patient population. And we're here for the long run. And I appreciate the time that we spent.
Well, thank you. And I let me also offer an invitation. We have the AutoNation Cancer Research Center here at Nova Southeastern University. So if any of your folks want to reach out for collaboration, I know that we're collaborating with Georgetown and with Johns Hopkins or whatever, but you know, you're the neighbor, so just reach out. Thank you very, very much for giving us your time. I know how busy you are, and we're very proud of your presence on this show. So thank you very much. Folks, I always tell you that this is your show. You ask questions. We try to bring the answers to you through our visitors and our participants. Thank you very much for showing up. If you have a question or otherwise, there's an email address right here. We'll refer them on to Dr. Moskowitz. If he wishes to answer, we'll let him answer. And that's his privilege. And I just want to let you know that if you have a problem, just like he said with his mom with the little node, if you have a problem, don't hide anything from your doctors. Let the doctors know what's going on. Don't tell them that you went to a supermarket or a pharmacy to buy something over the counter to take care of it. Make sure you let them know what's going on, please, because your health care is driven by a great sense of your communication with your physician. Remember, this show is called Dateline Health. We come to you from Nova Southeastern University. And until next time, my name is Fred Lippman, and this is Nova Southeastern University. See you.